Good morning, everyone. I'm presenting on behalf of Medicine 2. So, 36 years old male from Velur presented with the complaints of a fever for 5 days and left-sided neck swelling for 5 days. History of present illness and fever for 5 days, which is a high grade associated with the chills and no rigors and no evening rise of temperature. And there is also associated left-sided neck swelling, which is over the posterior aspect of the neck, which is gradually progressive and with no first discharging sinuses. And but there was no issue of dental pain, sore throat, cough with expectoration, breathing difficulty. There was no history of loss of weight, loss of appetite, any abdominal complaints or abdominal pain, loose stools, vomiting. So past history, he has no known comorbidities. So coming to examinations, he is vitally stable. Blood pressure is 110/80 millimeters of mercury. Pulse rate is 100 per minute. He is febrile at the time of presentation and saturation maintaining at 96% at room air. So this is the local examination. This is the picture taken from the Google, but the patient also has a similar finding. So there was a neck swelling which is noted at the left mastoid tip, which is extending into the neck, and the size is around 7 cross 5 centimeters, which is a well-defined swelling and which is erythematous and tender and which is fluctuant also. He also found to have bilateral subcentimetric posterior cervical nodes. So all the systemic examinations are within the normal limit. So for the fever with the syndrome complex of fever and unilateral neck swelling, the differentials we considered were parotitis, mumps. First considers lymphadenitis. Second differential is parotitis, mumps, infectious mononucleosis, or parapharyngeal abscess, or sialolithiasis, or Castleman disease, and the rare less likely to be Bartonella and tuberculosis also considered. So the initial investigation showed total counts within normal limit 8,600 with neutrophils of 64%, and there was a hyponatremia, which is sodium 128, a creatinine within normal limit 0.91, and urine routine showed no evidence of pyuria. So this is the blood culture sent, and the patient blood culture has grown Salmonella typhi within 12 hours after sending the blood culture. So we have done USG neck and the CT neck. So USG neck showed diffuse subcutaneous edema and soft tissue inflammatory changes in the lateral aspect of the left cervical region with extension to the posterior aspect of the neck on the left side. So, but which is not non-liquefiable. And there was a few subcentimetric level 5 lymph nodes also noted. So we proceeded with CT neck. CT neck showed that is, in addition to subcentric cervical lymph node body, there was an evolving abscess in the left proximal posterior triangle. So at the end of all these findings, the diagnosis we considered was enteric fever with a neck abscess. So I'm just justify why we considered that the enteric fever is neck abscess. So the enteric fever with the neck abscess is one of the rare extraintestinal manifestation of the Salmonella typhi. Sir? Yes, sir. It was already grown. Yes, sir. It has grown within 12 hours of presentation. So, which is a rare extraintestinal manifestation of Salmonella typhi. Only up to approximately 20 to 25 cases reported so far. So coming to Salmonella typhi usually the mode of spread is via contaminated food and water. It enters the intestine, and via in the intestinal wall it spread to the mesenteric lymph node, from mesenteric lymph node it enters the blood and spreads to the other organs of the body. So the mode of spread for the extraintestinal involvement will be either hematogenous or lymphatic disseminations, and in some groups there will be a lymphatic vessels in the tonsil tissues also can directly through the oropharynx also is the other mode of spread. So these are the extraintestinal manifestations so far observed with the Salmonella typhi. They are splenic abscess, liver abscess, pyomyositis, meningitis, osteomyelitis, and septic arthritis. So this is the article published in Lancet in 2005. So there they found that the soft tissue infections so far till 2005 there are 17 cases reported. And the risk factors found in those 17 cases was diabetes, and the complications, the soft tissue infections they found was psoriasis abscess, gluteal abscess, and cutaneous vasculitis. So these are the two case report for our evidence for our case. So this is the case report, Salmonella neck abscess as an opportunistic infection, diabetes mellitus. This case report is published in 2013, and it found that the patient presented with in uncontrolled diabetes mellitus, patient presented with fever and neck abscess. And the pus culture from the neck abscess has grown Salmonella typhi. And with the antibiotics, the patient condition not improved in this case. So they have done the incision and drainage. For this case, first 2013 published case, and this is the our case published in Apollo Hospital, Chennai in 2023. Here also patient found presented with a fever and neck swelling. There also pus culture has grown Salmonella. Those also initially they tried with antibiotics, but the swelling, the abscess not resolved. So they have proceeded with the incision and drainage. So so far the 10 to 15 cases as reported. Among all cases, along with antibiotic, they have done surgical incision and drainage. And also they found that these are the risk factors associated with the Salmonella typhi patient presenting as a neck abscess, like diabetes mellitus, malignancy, HIV infection, and immunosuppressive therapy. So in our patient, initially we didn't do pus aspiration because initially the abscesses are non-liquefiable. But after 12 hours, we started the patient on azithromycin and ceftriaxone. In the same way, our patient, the neck abscess swelling is also continues to progress. So on 1st August, we have done repeat ultrasound screening. It showed that is the increase in the swelling, and it become liquefiable also. In that time, we have sent pus swab, but in the, that pus swab has shown no growth so far. The final report still awaited. But what we thought is because the patient already completed 4 to 5 days of antibiotics, so that might be the reason for the no growth in the pus culture at the end. And also we have screened our patient. Our patient has no comorbidities for the risk factor for developing extra-intestinal Salmonella typhi, and we found the patient HbA1c is 8.3%. He found a newly diagnosed diabetes mellitus, and all seropositive infections we have excluded. So after incision and drainage, our patient is afebrile for past 3 days and has completed 7 days of antibiotics. And he is afebrile and discharged yesterday, sir. My learning points are various extraintestinal manifestations, Salmonella typhi infection, and clinical profile of patients with extraintestinal seedings.
Thank you. Very interesting case. One question: why does this patient have polycythemia?
He is a smoker also, sir. We have planned to evaluate on OPD basis, sir.
Any questions from the house?
Yes, we have switched to susceptible to quatrimoxazole also. So we have completed 7 days of ceftriaxone and switched discharged on quatrimoxazole.
Questions from the house? If not, thank you very much, everyone, and thank you to all the presenters especially.